recorded, so for posterity purposes, just mind what you say. And if you're not actively asking a question, if you would go ahead and mute yourself, that way it doesn't sound like a banshee screaming over my end of the computer whenever you drop something or what have you.
How the hell you mute yourself?
I just took care of it, Tommy. All right. First thing we're going to go over is the emergency medical services system. So EMS can trace its roots back to the French in the 1790s. So around the 1790s, early 1800s, the French would use dedicated personnel to transport wounded soldiers away from the battlefield back to a field hospital. This is the earliest documented case or instance of EMS in the world that can be found. This process was continued in pretty much every major combat engagement to follow. So in the Civil War, the American Red Cross, under the leadership of Clara Barton, began providing the same service for both wounded Union and Confederate soldiers. And they would have dedicated uh, medics, if you will, that would run into the combat zones, get the wounded soldiers, and bring them back to the field hospitals. They weren't providing a lot of treatment; they were mainly just transportation. But that's how everything kind of got started. So fast forward to World War One, the Red Cross is still doing pretty much the same models they were doing in the Civil War, except now they're using vehicles. So they have volunteers, both male and female volunteers, that would go into these combat zones, into the trenches in World War One, and remove the wounded back to the field hospitals. Now you start getting into World War II, Korea, and Vietnam. The medics that were being used at that time actually began providing care. So that's where our point of care side of EMS kind of came from. Started around World War II, Korea, Vietnam. Pretty much everything in EMS can be traced back to the military or to a major war at some point in time. So in World War II, Korea, Vietnam, medical teams would provide uh, point of care for wounded soldiers. They would provide bleeding control, IV therapies, medication administration, all this other stuff that eventually got rolled back into uh, the civilian sector. Now, on the civilian side, the first non-military ambulance services began in major U.S. cities around the early 1900s. But again, until these wars came about, they still provided very little to no patient care whatsoever. So most of the time, uh, they're operated by either the fire department or the funeral home, believe it or not. They would double purpose the hearse. And they would just get you in it and they would run, as fast as they could to get you to a receiving hospital where a doctor would actually initiate care. So you may be laying back there bleeding, dying, not be able to breathe, whatever the case may be, but you weren't actually getting any care until you get to the hospital. Around the late 40s, early 50s, on into the 60s, we recognized there was a need for change in this country and in EMS in general. So the Department of Transportation was tasked with developing a set of EMS standards. So this provided a scope of practice. This provided skill sets, what the ambulance attendants could and could not do. Uh, then in 1970, the National Registry of EMTs was established. The National Registry of EMTs is kind of our overseeing body nationwide for where all of our standards and practices come from. And the purpose of this was to further standardize across the U.S. the level of care that people were getting, because you would have people, in New York City who were being treated by ambulances that were, well funded, well stocked, well trained, and their people were able to go through these training courses because the resources were available in New York City. However, in Sheridan, Arkansas in the 1970s, those same resources may not have been available because there was no real standard for more rural areas until the NREMT established those. And so what that did is nationwide established a training base, a set of standards, a scope of practice, everything else for EMS providers to work under. So the National Highway Transportation Safety Administration established these standards for EMS systems. First standard they established was a regulatory body and some policy. So each state would establish laws that would govern EMS. They would establish a lead EMS agency, usually some sort of subsidiary of the health department, a funding mechanism, whether that's tax-based, grant-based, or however you may be, the states will provide for that. They would also provide policies, procedures, and regulations that were based on those national guidelines set forth by NREMT. They also established for resource management. So they provided a centralized coordination area for emergency treatment and transport resources. So there was a standard that everybody followed, that everybody could meet for how these things were being done in the field. Uh, then the NHTSA standards also established EMS systems should provide human resources and training. What this does is, like I said, it doesn't have that large gap from where you may have an urban area EMS with its well funded and well trained. You still could be able to receive the same standard of care in a very rural area of the United States, and also provided standards for how you should provide safe and reliable transportation. The NHTSA established the closest appropriate facility guideline, which is where EMS providers should, if possible, transport patients to the closest, most appropriate facility to further expedite their care. It also had played a role in the establishment of the 911 system. So the Universal System Access Number, so 911, would be able to provide a direct link from callers to EMS agencies, where before it was, you know, there would be brochures and flyers and billboards and everything else with these different ambulance services phone numbers. People either had to have written down or jotted down everything else. This brought EMS out from the private sector essentially, or from a subsidiary service, and brought them into the world of emergency response. Also established public information education standards, uh, established access for EMS providers for injury prevention, and would help educate the public about what the role in EMS did. Around this time is when the show Emergency came out. That's when people actually started learning what a paramedic was. Until that time, nobody really knew. They saw ambulances, they saw them running, nobody knew what they could do. So those times when the shows started coming back, people started learning, okay, yeah, these guys can actually do a whole lot. Uh, Established a medical direction system. So each EMS system is managed by a medical director who is a physician that is responsible for overseeing care for these services. It directed each state to establish a trauma system, which has a set of trauma triage, transport, and treatment protocols. Ours is done under Arkansas TraumaCom for the state of Arkansas. It also established evaluation standards, so how we could provide quality assurance, quality information, data management, and things like that. Any questions so far? All right. So different components of the EMS system. So the EMS system begins with the emergency medical dispatcher. So the emergency medical dispatcher works in a dispatch center just like every other dispatcher. However, they are trained to provide a little bit higher level of response and care and knowledge over the phone to help kind of initiate some care by talking to bystanders, and also to be able to help kind of adequately triage what type of call these ambulances are being dispatched on. Then you have your EMS responders, which are your EMRs, your EMTs, your advanced EMTs, your paramedics. Those are your people that are in the field working. All right, then you have your emergency department personnel. So your doctors, your nurses, your respiratory therapists, all your other allied health professions. That's kind of your definitive level of care. Other things you will deal with at an EMS system are specialized care facilities. So you have your trauma centers, you have your burn centers, your pediatric centers, cardiac centers, stroke centers. Each hospital that may otherwise be a generalized hospital may also have a specialized designation. So, like in Arkansas, different hospitals are categorized as a level 1, 2, 3, or 4 trauma center if they participate in the trauma system. It's also different hospitals that can be classified as burn centers. Currently, Arkansas Children's Hospital is the only one in the state that is categorized as a level 1 burn center. There's pediatric centers, cardiac centers. Cardiac centers usually have to maintain either a cardiologist on duty or on call, cath lab capabilities, different things like that. And there's stroke centers. This has also been pushed a lot in recent years. So where there's R saves, and we'll talk more about that when you get into the stroke chapter. But there's R saves, so there's different hospitals that can handle different capabilities when it comes to strokes. So these are all things that, working in an EMS system, you need to kind of get familiar with your area and with your hospitals and what can do what. So when accessing the EMS system, there's a patient, a citizen or the patient calls 911, is connected to an emergency medical dispatcher, who then dispatches the emergency medical responders or rescue staff, who then hand off to your EMTs, your advanced EMTs, your paramedics, your ambulance crew, right? Who then brings them to the emergency department staff, which then follows up with allied health staff or some other form of specialty care. The whole goal for all of this is a phrase that I was coined by our medical director for Pafford that I like to steal every chance I get because I think it's awesome. But the whole purpose of EMS is to have a perpetual motion to a higher level of care. So from the time you start to the time you finish, that patient should steadily be moving up in levels of care. So they should go from either being by themselves or with a bystander to being with a first responder to being with the EMS crew to being with an emergency department physician to being with a specialist. It's always a perpetual motion to a higher level of care. So the way you access the EMS system, like we talked about earlier, is through 911. That's universal across the United States. Uh, there's enhanced 911 in some areas, which provide the caller number and location for landline phones. So that's just kind of an additional tool for the emergency medical dispatcher to be able to get a more accurate pinpoint location for everything that's going on. EMDs can also provide instructions on how to provide emergency care until EMS personnel arrive. The most common example of this is if you have a patient who is in cardiac arrest, they're not breathing, they don't have a pulse. An EMD can actually talk a bystander through how to perform CPR until either first responders or the ambulance crew arrive to take over that care. Just a second. Some other skills you have to have in this profession, you have to be able to have critical decision making skills. So it's a very important concept in EMS. You need to be able to gather information from a scene, perform a patient assessment, gather information from other sources, interpret that information, and then make a decision based on that information. If you don't have enough information, you need to be able to ask more questions, more pointed questions, perform additional examinations. It is essentially like being a detective for healthcare. You need to be able to take nothing, a blank scene, chaos going on, and make sense of it. That way you can provide care for your patient. So some examples of some of these decisions. So should you take your patient to the closest hospital or a more distant specialty center? Well, your decision on that is going to be based off a number of factors. Is your patient stable? Are they unstable? You'll learn more about that as the class goes on what classifies stable versus unstable. Are they able to make the trip to a more distant hospital to get a higher level of care than they would get at a local emergency department? Or do they need to be stabilized first and transferred out later? Uh, Another example, will this medication help make the patient's current condition? Would it make the condition worse? Could it make it better? Could it make it worse? Those are all things you need to be able to learn and interpret by knowing, what kind of care you can provide as an EMT, how that care would help or hurt your patient, and therefore should you do it. As far as certification and training goes, there's four general levels of EMS training. There's your emergency medical responder. That's your baseline. A lot of your fire departments are using those. I say that not really anymore. Most places are requiring EMT, but originally a lot of your fire departments would only require EMR. That's a very basic level. It's an 80-hour course, uh, 40 or 80 hours, one of the two. Very short class, uh, very basic level of knowledge, but it's higher than your average bystander. Then there's your emergency medical technician course, the EMTs. That's the class that you're in right now. That's kind of the baseline uh, for professional EMS, at least in this state. Then you have your advanced emergency medical technician, which is kind of bridges the gap between EMT and paramedic. They have the same skill set as an EMT with a few added skills in between there, such as IVs, a few levels of advanced airways, a couple of medications they're allowed to, more medications they're allowed to administer. Then there's paramedics, which is your highest level of care in emergency medical services or pre-hospital care. So paramedics can perform all virtues of or all facets of advanced airways. They can administer a host of medications. They can perform all sorts of uh, like serious interventions for your patient. Any questions so far? If you have a question, don't be afraid to unmute yourself and ask it. Your roles and responsibilities as an EMT include your personal safety. Your personal safety is paramount always. If you are not safe or if you get yourself hurt or put in a bad situation, you are of absolutely no use to anybody. You cannot help your patient. You cannot help your partner. You cannot provide care. So the number one rule in EMS is don't become part of the problem. The way you don't become part of the problem is by keeping yourself safe at all times. After that, it becomes the safety of your crew, your patient, and bystanders. Make sure nobody else becomes part of the problem after you get there. You don't want to make a small scene big by a bunch of people trying to do a bunch of stuff that's not safe. You have to be able to work with other public safety professionals. You have to be able to interact with fire departments, law enforcement agencies, emergency management agencies, utility companies, you name it. You're going to have to interact with them at some point. You need to be able to provide a patient assessment, know what your patient assessment results are, and provide care based on that assessment. You need to be able to lift and move a patient within reason. You need to be able to provide safe and efficient transport. You need to be able to provide a sound transfer of care to a higher level of care. So whether that's an ALS intercept or receiving emergency department, we'll get into more to that as you get into your assessments. And then you need to be a patient advocate. Patient advocacy is one of our most important functions as well. We are coming to these people on a very bad day. We're coming to these people when they are having a serious problem and they may be alone. There may be nobody else to speak for them. So you have to speak for your patient. You have to make sure your patient gets the care they need and is treated appropriately. You are their voice. Some physical traits that make a good EMT. You need to be able to lift and carry equipment up to 125 pounds. This stuff is not light. You have these bags, you have oxygen, you may have a Lucas device, you may have a ventilator, you may have a cardiac monitor, you may have a stretcher, a stair chair. You may be having to carry a lot of things. Generally, you're going to have some manner of help, especially around here. But you may get out in some of these more rural areas where it may just be you and your partner. And between y'all need to be able to get all of this crap in there to this patient. You need to have good eyesight, either naturally or be able to be corrected. You can't be blind as a bat going out around here trying to provide care. It's just not going to work. So either have good eyesight or be able to wear glasses, contacts, have the laser surgery, whatever the case may be, you need to be able to see it efficiently. You need to be aware of any problems with color vision and how that may impact your job. Does this gray medication look more gray? Okay, well, let's give the gray one. See how that could become a problem? You need to have good communication skills. Be able to talk efficiently, talk to people, convey information, make sure they understand what you're trying to say, and good written communication skills. After every call you make, you will have to fill out a patient care report. That patient care report is a legal document. That legal document may be the only thing that you have to refer to when this call goes to court in 3 to 5 years. So you're relying on your own communication skills in written form to be able to provide testimony or defend your actions in front of a court, a board of inquiry, or what have you. Some personal traits. You should be pleasant, sincere, cooperative, resourceful. We're not there to be a jerk. Okay. They're calling us because they need us, or at least they think they need us. So we need to be able to, it's a customer service job at the end of the day. It's a customer service job with lights and sirens. You need to be able to provide the best customer service, in this case, patient care, that you can. You can't do that if you're being a jerk. You need to be able to maintain a professional appearance. This guy here, he has his shirt ironed, his shirt's tucked in, his pants legs aren't tucked into his boots. He's got his gloves on, he's got his eye protection on, he's got his bag. He walks up to a scene looking like he might know what he's doing. He may not have a clue what's going on here, but a good appearance will breed confidence in everybody around you. And the fact of the matter is, when they call you, they're having an emergency in their own mind, whether it is a real emergency or it's, some stupid stuff that they called us for. It's not our place to decide. It's not our place to judge based on that. We have to inspire confidence in them. And the way you do that is by maintaining a good professional appearance. You need to be able to be a self-starter. You may be in a rural station by yourself, just you and your partner, where your next closest backup truck is, 45 minutes away and over three, donkey paths and a washed out creek bed. You need to be able to make do with that. You need to be able to be emotionally stable. This is not saying you have to be a robot. You just need to be able to process your emotions efficiently. There is going to be times in this profession, if you do it long enough, where you're going to get into some stuff that's going to bother you, and that's okay. There's a time and a place to deal with it, and there's ways to efficiently and healthily deal with that. And we're going to talk more about that in the next chapter. But you need to be able to make sure your emotions are in check while you're trying to do your job. You need to have some semblance of leadership skills. You may have to direct your partner, the fire department's on scene, other first responders, bystanders, law enforcement. You may have to start orchestrating a symphony here on a critical scene to help get this patient or these patients, multiple, what they need. You should be neat and clean. You do not want to get in the back of an ambulance that has blood, mud, and guck all over it. You do not want to get in the back of an ambulance that looks like somebody took a grenade, threw it in there, and set it off, and it shuffled up all the supplies. You need to be able to maintain cleanliness, neatness, and professional appearance. You need to be of good moral character and respectful to others. We don't need to be worrying about you stealing stuff on these scenes. Nobody, that should not even be a thought that enters anybody's head. You should be able to work efficiently and respectfully with other providers. You need to be in control of personal habits. If you're a nail biter, if you're a hair twirler, if whatever, what have you, you need to be able to make sure that that does not interfere with your ability to perform your role. You need to be able to be controlled in conversation. Don't fly off at the handle. All right. Don't fly off at the hip. Make sure that you can communicate properly to everybody around you, whether that's the patient, the patient's family, other responders, emergency department staff, anybody you may have to talk to. Make sure you can communicate properly with them. You need to be able to listen to others. This is one that is often lost on a lot of people. They may hear you, they may not be listening to you. The patient's family will try and give you information. And it may be a patient you've picked up 173 times because they have some sort of chronic condition. And you're just like, oh my gosh, shut up. I know. I've been here 103 times. However, that patient's family is with them 24/7. You may be with them 30 minutes to an hour at a time every third week. Okay. They know what's going on. Listen to them and be non-judgmental. Be fair to your patients. You do not have to agree with their choices, whether lifestyle, physical, whatever, what have you. It is not our place to judge. There is no place for politics, personal beliefs, religious sways, anything like that when it's time to take care of a patient. It is not our job to provide selective care based on your own personal beliefs. Everybody gets the same standard of care. It's more of the responsibilities you have. You have to maintain up-to-date knowledge and skills. You will do this every 2 years. You have to renew your license for both National Registry and the state of Arkansas. You will do this through either a refresher course, attending continuing education courses, attending conferences, seminars, lectures. You have to obtain 40 hours of continuing education every 2 years. This is the reason we do this because this is a job that is ever changing. There's always new stuff coming down the line. There's always new things that are happening. So you need to be able to stay current and know exactly how to provide the best level of care you can. And the way you do that is by continuing education. That's why we are requiring you as NREMT, the state of Arkansas, to maintain 40 hours of continuing education every 2 years. Different places you can work as an EMT, obviously at an ambulance service, a fire department, a rural or wilderness type team, such as a search and rescue squad, urban and industrial settings. A lot of factories and industrial complexes are now hiring EMTs as responders and healthcare providers in their factories and in their job sites to help kind of cut down on some of their liability. Volunteering, there's different volunteer organizations you can work with as an EMT, not just volunteer fire departments, but there's the Red Cross. There's all sorts of other things that you can work and do as an EMT. So the National Registry of Emergency Medical Technicians, or the NREMT, y'all all made an account with them on Wednesday. Uh, is kind of the overseeing body for certification of EMS providers in the United States. It provides registration for EMRs, EMTs, advanced EMTs, and paramedics who successfully complete all the requirements, including the NREMT exam. Uh, some states do not require you to be registered with the NREMT. Most do. Uh, if you have NREMT certification and you go from one state to another, it's a whole lot easier than if you're just going with state certification. And a lot of employers are also requiring you to have NREMT certification. The state of Arkansas does require you to maintain NREMT certification, or else you cannot hold a state license.
Hey Jake, I got a question about the going from state to state. You would usually have to take a test whenever you go to do if you like transfer, say from here to Missouri or Tennessee. You would usually have to take a test to be able to practice in that state with your NREMT, correct?
So not necessarily. There's some states that may require you to take like a test over their regulations, but it's not going to be like a patient care type test. So like I know uh, I'm licensed in one, two, three, four. I'm licensed in 5 states, and I only had to take a test for Texas. The rest of them, I just had to apply for reciprocity and then fill out their background forms and pay their licensing fees. And then because I had an Arkansas state license and an NREMT certification, I was granted reciprocity because I hold a license in Oklahoma, Texas, Arkansas, Louisiana, Mississippi. So it's kind of varies from state to state on what they require you to do. But the only one I had to take a test for was Texas, and it was based on like their EMS laws and regulations. It wasn't really based on anything patient care related.
Okay, thank you.
An aspect of EMS systems is quality improvement. So EMS systems are tasked by the NHTSA. We talked about them earlier to establish a quality improvement program. So what quality improvement is a self-review for the purpose of identifying aspects of the system that require improvement. Basically, it's an internal audit. We investigate ourselves to see what are we doing right, what are we doing wrong, how could we have done this better, and based on that data, we should be able to provide a plan to correct any deficiencies, improve performance, provide more training, provide more education, and everything else based on how that quality improvement review is done. Everyone in the organization will have a role in quality improvement. It may be as simple as preparing carefully written documentation. So, like I said, you have to have strong written communication skills. You will provide a complete and accurate report. Not only may it back you up in court, but it's also going to assist in quality improvement. Because if they read your report and they're like, hey, why did this guy, not give this medication or why didn't he do this way? They're going to ask you about it. And you may have a perfectly good justification for it. And it may be that you just forgot. And they're okay, well, this is a good opportunity. This is a good teaching moment. Make sure you do this, and here's why, and this, that, and the other. Or it may be that you had a perfectly valid justification for why you did it your way instead of the way that's it's normally done. And that may cause the company or the regulatory body or whoever be like, I never thought about it like that. And from that point forward, they may start training and researching how you did it, and that may become the new standard. So it's important you provide a carefully written piece of documentation after every call. You may become directly involved with the quality process. You may be one of the ones that's reviewing different people's reports and calls and everything else to try and make sure everything is going the way it should. Uh, there'll be people in your organization that obtain feedback from your patients and from hospital staff on how they were treated, how your care was, and everything else. Just a second. So every system is required to have a medical director. So all patient care will be performed under that medical director. That medical directors are physicians who oversee the clinical portion of an EMS agency. They have the ultimate responsibility for patient care. They're supposed to oversee training, develop your patient care protocols, issue your offline medical direction and or which is your standing orders that'll be, inside your protocols, what you can do all the time without asking permission. And they also provide what's called online medical direction, which is where you can actually call and speak to them while you're on a call. Be like, hey, doc, I've got this. I want to do this. And they're going to be like, okay, yeah. Or no, don't do that. Do this instead. That's online medical direction. So your offline medical direction are your treatment protocols, uh, everything else. But it is a physician whose license you ultimately work under. EMS also has a role in public health. It can be as simple as injury prevention for geriatric patients and youth. For example, if like this lady here, if she sees that this rug on this slick floor is a potential fall hazard, she's telling them about it. They're like, "Oh yeah, look there. I never even thought about that. That's great." And so just trying to prevent another emergency from happening if you see something that can be prevented. You show up to a house and there's a crib or a pack and play for a 6 week old that's chock full of stuffed animals and blankets and everything else under the sun. You're like, maybe let's not kill the baby. Let's take all this stuff out. Let's practice safe sleep. Do it with more tact than that, obviously. But it's just preventing injury, preventing any kind of, try to prevent yourself from being needed as best you can. You may be called upon in EMS to perform research. Uh, Research affects EMS in several ways. It improves patient outcomes uh, through evidence-based techniques. So basically, we take what we have found, what we've seen, what we've researched, what somebody else may be doing, a different way of doing things. We find some clinical backup for it, and we pitch it. Like, have you ever thought about doing it this way? Let's look into it. Let's figure out if this is better than what we're doing, or this is worse than what we're doing, why we like it, why we don't like it. Let's figure it out. 'Cause what we're trying to do all the time is make this better. This is an ever-changing field. Uh, Through performing research, you'll have to it's an evidence-based process. You have to make a hypothesis, review literature, evaluate the evidence, and then adopt the practice if the evidence supports it. If the evidence doesn't support it, well, your project's dead in the water. Not every place requires you to do this. Some services you work for may require you every so often to participate in a research study. I have to be on them all the time. It gets a little annoying. Uh, so through EMS research, the dynamic nature of treatment makes research difficult. What that means is we deal with so many different types of emergencies, so many different types of patients. Not everything is done the same way. So that's why we embrace the best practices and use the evidence-based approach to perform our research because we deal with so many different types of things. We rely on the scientific method to do so. We take our general observations, see that we've seen this, we've thought about this, we form a hypothesis. Hypothesis meaning, I wonder if this would work better. And then you test to prove or disprove your hypothesis. We've already done all that. We've had your orientation already. Anybody have any questions over chapter one?
No, I'm good.
Comments, concerns, donations? Does anybody need a break? You want to power through?
Let's just keep going.
Power through. I like it. Let's do it. All right. Next thing we're going to discuss is the well-being of the EMT. In this job, it is very taxing, both physically, mentally, emotionally. It's a high-stress occupation. So you need to make yourself prepared for the demands and risks that you may take as an EMT. If you're unable to function for any reason, the patients may not get the needed care. It's like I told you in the last chapter. If you become part of the problem, you're no good to anybody. So make sure you're always ready to go. Make sure you're safe. Make sure you're healthy to perform this job. You can maintain your well-being by having solid personal relationships. Have friends. Have friends you can talk to. Have, good influence of friends. Exercise moderately. Sleep enough. Eat right. And anybody who's ever worked in emergency services is laughing their butts off right now about all those three things right there. But it's true. If you do maintain some level of physical fitness, if you try to get some level of decent sleep schedule, if you're when you're not on shift, if you're on shift, just kiss that goodbye. It ain't happening. Try to eat right, try to eat as best you can, then you're going to feel better, you're going to be healthier, and you're going to be able to perform the job better. Try to limit your alcohol and caffeine intake. It's not good for you. Uh, Everybody who's ever done this job for any period of time will tell you that at some point in time you're running on caffeine and nicotine. It's not the best way to be. That's how mistakes happen. You need to try and limit that as much as you can. Go to your regular checkups, keep up to date on your vaccines. Make sure that if you need medication for something that you get that medication or taking it. If you have high blood pressure, you don't need to be running an ambulance with a blood pressure of 220 over 110. All right, you're going to stroke out on the floor and now your partner has two patients to take care of. While working as an EMT and through the entirety of this class, whether you want to or not, you will take standard precautions. So you will wear protective equipment. Reason being is you will come in contact with all sorts of nasty. Nasty contains pathogens. Pathogens cause infections. Okay, they can be bloodborne, airborne, they can be droplets, whatever the case may be. Standard precautions are steps that protect yourself from pathogens. It keeps all the nasty off of you, or as best off of you as you can. When you see the patient, you will make a decision on which standard precautions you're going to wear. The things that's never going to change is you will always wear gloves. You should always wear some form of eye protection. If you choose not to wear eye protection, get spit in your eye by a junkie one time. You'll wear glasses the rest of your time in EMS. Okay. OSHA has strict guidelines about precautions against exposure to bloodborne pathogens. That's why you will wear gloves. Period. End of story. While you are doing clinical rides for this class, I ain't taking a chance with y'all getting coming in contact with some nasty and having some lifelong lasting stuff because of it. Different types of PPE you may wear. So you have your gloves, you have your N95 mask, your surgical mask, your HEPA filters. Some of these masks may have a face shield on them, so it doubles your goggles on and everything else. If you wear regular eyeglasses, that's fine. That works. That protects your eyes. If you don't, get you just a pair. They don't have to be those big old Urkel looking things right there. Get you a pair of discreet safety glasses and wear them while you're on calls. You'll thank yourself if you ever get spit on in your face. Always have non-latex gloves readily available. Used to, everybody wore latex gloves. Uh, there's too many people have latex allergies anymore, so pretty much every glove you wear now in EMS will be vinyl. Uh, if you go from patient to patient, make sure you change your gloves, either by discarding them or putting on a new glove over it. You don't need to be taking one patient's nasty and putting it on the other patient. Uh, wear heavyweight, tear-resistant gloves whenever you're dealing with the equipment, cleaning the ambulance, anything where there's a higher risk of the glove being torn. Double up your gloves, wear some thicker gloves, just protect yourself. The way you take a glove off is just like they're doing there. So you take one hand, fold the glove inside out. Now you got that glove that's inside out, hold it held in your other hand that is still gloved, and then you do the same thing. Now you've got two gloves inside of each other and you dump them in the trash. You need to wash or at least clean your hands with hand sanitizer between every call. Either with soap and water, hand sanitizer. Make sure you're doing some form of hand hygiene between each and every call. Talk about masks and eye protection. Some other PPE you may require to wear is gowns. So for some of these patients that may have some what's called contact precautions, like maybe your TB patients, patients with other pretty serious illnesses that are highly contagious, you may wear a higher form of body isolation. So you may end up wearing a gown to keep any kind of droplets or anything like that from getting on you. If the patient is extremely soiled or bloody, you might just put a gown on just to keep the nasty off of you. I've done that. It's different infections you may come in contact with. That's why we wear PPE. Hepatitis B and C. Hepatitis is an infection that causes inflammation in the liver. It's nasty. It messes you up. It can live on the surfaces of dry blood for several days. Just because it's old doesn't mean you can touch it. Don't touch it. Hepatitis B is deadly. It killed hundreds of healthcare workers each year before a vaccine was available. And hepatitis C is just as deadly. However, there's not a vaccine for it yet, which is why you may have to make sure that you wear your body substance isolation at all times. Tuberculosis is a highly contagious lung disease. It is airborne. It is spread through droplets and floating throughout the air. AIDS. So AIDS starts off as HIV, which is human immunodeficiency virus. It attacks the immune system, which leaves you unable to fight off an infection. AIDS is a autoimmune deficiency syndrome, which is what happens when HIV progresses to the point where you have so many conditions that the immune system can no longer fight off anything because it's been attacked by HIV. HIV and AIDS is actually a much lower risk to healthcare workers than hepatitis or TB is. Uh, you usually have to get their blood in your blood pretty much to get HIV or AIDS. Some other diseases of concern, there was Ebola. There was an Ebola outbreak back in 2014. It caused a hemorrhagic fever, which we'll go over that more, what that actually means later on in the class. Uh, there's high rates of death and lack of definitive treatment. There's SARS, severe acute respiratory syndrome, and then MERS, Middle Eastern respiratory syndrome. Both of those are respiratory diseases. Why you need to wear your mask when you're dealing with anybody that's coughing or everything. It's not just surgical mask. You need to wear your N95 with anybody that you're concerned with having a contagious respiratory disease, something that's actually going to stop some particles. The avian flu, influenza. Influenza comes around every year. It stays around every year. It kills people every year. So it's something to worry about. So one of the major causes for concern in EMS is an exposure to bloodborne pathogens. So OSHA has a standard on how to deal with bloodborne pathogens, and it requires an infection control officer to be appointed by an employer. However, infection control is the responsibility of both the employer and the employee, or in this case, both Pafford and you, the student, responsible for mitigating a bloodborne pathogen incident. Excuse me. Ways we mitigate exposure risk for bloodborne pathogens is we have an infection exposure control plan. We provide adequate education and training to our employees. We provide access to vaccinations. We provide you PPE. We provide you methods of control, proper housekeeping. So like we have the red bin trash for anything that's soiled with patients' bodily fluids or anything else like that. Proper labeling, and then post-exposure evaluation and follow-up. A win for EMS and the legislature was the Ryan White Care Act. This allows EMS providers to find out if they have been exposed to a potentially life-threatening disease while providing patient care. Uh, there will be the hospitals are required to report that to the EMS agencies. We will then follow up with us. We will follow up with you if that happens. If you have a bloodborne pathogen exposure, meaning you have a needle stick, you have a cut or you get cut on a scene and you're worried that you might have had an exposure, which means that you're worried that you might have been contaminated by the patient's bodily fluids in some way. You are required to immediately report it to the on-duty supervisor and to me. You all have my phone number. I don't care if it's 1 o'clock in the morning. If you're on a clinical ride, you need to be calling me immediately because I'm gonna have to come up there. And you have to contact the on-duty supervisor, whose phone number you will be provided with by the time you start your clinical rides. We're talk about that. We're talk about that. Anybody have any questions so far? Nope. Okay. All right. EMS is a highly stressful occupation. It is inevitable. We deal with things, we see things, we smell things, we hear things that nobody else is supposed to see, supposed to smell, or hear. It is important to recognize the signs of stress and develop strategies to deal with that stress. You need to have a healthy coping mechanism. EMS providers are going to have a level of toughness or a level of resilience to overcome these situations. Uh, it will help you deal with difficult situations. It will help you power through a tough call. Uh, the way you build this resilience or this mental toughness is to understand stress, be physically and mentally able to respond to that stress, and then use techniques to mentally process those difficult scenes. There's a couple different physiologic aspects of stress. There's your first stage, which is your fight or flight. That's your alarm reaction. All right, then there's your second stage, which is your stage of resistance. It's your coping mechanism. Then there's your third stage, which is exhaustion or the loss of ability to resist or adapt to the stressor. We want to try and avoid you ever getting to the third stage. The third stage is where it becomes dangerous. That's where you start getting burnout. It's where you start getting all of these other problems associated with stress. That's why we want your second stage, your coping mechanism, to be healthy, to be able to adequately process everything that you see out here in a efficient way and in a healthy way, so you can deal with it, cope with it, and be able to move on. So there's a couple different types of stress reactions. There's a critical incident stress reaction, which could be any incident that triggers a strong emotional response. Uh, Everybody's different on that. There's some people who have certain things that if they see it, if they're type of call, if they go on that type of call, it messes with them. It messes with them hard. It may mess with them right then. Uh, and there's your acute stress. That's your acute stress reaction. It's usually linked to a catastrophe, a severe incident, a major incident, a large scale incident. Uh, your signs and symptoms of this will develop soon after the incident. You'll have physical, cognitive, emotional, and behavioral symptoms. Uh, that these are normal. That's a normal reaction to to an extraordinary situation. But you may still require some sort of professional intervention. If that happens at any point in time during this class, we have resources at Pafford to help you with that. We have an EAP program that you will have access to with an online counselor, I say online, a counselor that's on staff that can call you and talk with you. But it is a perfectly normal reaction to a significant incident. It may result in irritability, nausea, uh, fatigue, anything like that immediately after a severe incident. Then you have your delayed stress reactions. Most common version of this is post-traumatic stress disorder. Just about everybody that's been in this profession long enough has some form of that, however mild. Uh, Signs of it is usually not evident until way after it's already said and done with. Uh, because of that, the delay in dealing with that reaction may be much harder. You may not realize what's causing the problem. You may just be irritated. You may just be angry. You may just be sad, and you don't really know why. But it's a delayed stress reaction. Your body is just now catching up to what happened to you way back when on that call that one time. Usually, this is going to require intervention by a mental health professional if it starts getting to the point where it's interfering with your ability to live your life. Then there's your cumulative stress reaction. It's most commonly called burnout. It results, it's years of sustained low level stressors, years of sustained, uh, you know, back to back acute stress reactions, untreated, uh, delayed stress reactions. The early signs of it usually is a vague anxiety, uh, boredom, apathy, emotional exhaustion, lack of compassion, all these other things. They're just burnout. Everybody knows what a burnout person is. Some different things that can cause stress. You have your mass casualty incidents, calls involving infants or children, especially people who have infants or children are especially tough. Severe or very morbid injuries can cause that. Abuse and neglect. If you see a call that involves abuse or neglect, sometimes that can cause a stress reaction. It could cause immense feelings of anger. Uh, or death of a coworker. I mean, if there's a line of duty death involved around here, that sometimes that can cause a stress reaction. Sometimes that's hard to deal with. There's a couple different types of stress, though, that you will deal with throughout this profession. There's eustress, which is it's positive, it's good, it helps you. It's that stress that when it's applied, it gets you focused. It's all right. Well, we got stuff to do right now. Let's get going. Then there's distress. That is a negative factor. It can cause immediate and long-term problems with your health and well-being. It's what's going to start getting you down over time. Some ways to deal with stress. Consider a lifestyle change. Develop healthy and positive eating habits. Take some time to exercise. Dedicate time to relaxing. When you're off duty, be off duty. If you're off duty, don't take this and try to do this at 18 different places like I do. It's terrible. Be off duty. Uh, Change the shift, change your location to a lighter call volume over time. Uh, Deal with trying to have more family time. So critical incident stress management is a comprehensive system. It includes education, resources to prevent stress. It includes ways to deal with stress appropriately when it occurs. One way this is accomplished is through a critical incident stress debriefing. Uh, if there's a large scale incident or a severe incident or a call that was really messed up that you recognize is going to cause some stress problems, we can set up a critical incident stress debriefing. We will bring in mental health professionals, counselors, other peers who would understand that you can talk to, and we will debrief the call. We're going to go through what happened. We're going to go through how we feel about it, and it needs to happen quickly. It needs to happen within 24 to 72 hours after the incident. It needs to happen fast. The reason being, it helps you deal with that stress before you start absorbing the stressors from it. You may have to deal with a patient uh, who's dying or who's dying. You may have to deal with or who's dead, and may have to deal with their family members. So some emotional stages. There's denial, anger, bargaining, depression, and acceptance. They may not hit all of these stages. They may hit all of them within 30 seconds. So the denial, the not me, or the anger, why me? All right, bargaining, I say, okay, I get it, but first let me. Depression, it's like, okay, but I haven't, whatever. And acceptance, okay, I'm not afraid. I can do this. Recognize the patient's needs. Be tolerant of an angry reaction from a patient or family member. I'm not saying let them beat the crap out of you, but understand they may be a little on edge if you're dealing with somebody, if you're dealing with a family of somebody who just died or the patient who themselves is currently dying. Listen to them. Offer as much comfort as you realistically can, but most importantly, do not falsely reassure them. We do not say the words to the patient ever. You're going to be okay. You're going to be fine. We got you. Don't worry about it. Don't ever say that. Instead, say, we're doing everything we can. We're going to do everything we can for you. Don't tell them they're going to be okay. Because if you tell them they're going to be okay and 3 minutes later they're dead, it's not good for you. It's not good for the family. So don't ever tell them, don't ever falsely reassure them. Just tell them, hey, we're going to do everything we can for you. Any questions? All right, into safety. Like I said, like I told you earlier, safety is the most important thing about this job. EMS by nature is not usually a dangerous profession. Reason we don't go around toting guns and driving armored vehicles. We're usually not on the blunt end of this. However, it's always a possibility. That's why you need to always be aware of any potential dangers. You need to determine scene safety on any call. It's the most important thing you can do on any call. It needs to be your first priority. If the scene is not safe, if it is something in there that you cannot deal with, if it's an unknown, if there is a aggressor, you need to back out and get law enforcement on the scene. That's what they're there for. That's their job to deal with that. It's not your job to go kick in a door and wrestle the domestic violence perpetrator away from the victim so that you can start rendering care to the victim. Let the police get there, deal with that scumbag, then start working on your patient. Don't put yourself in a bad situation. You may be called to deal with a hazardous materials incident. Happened to me a couple months ago. You may be the first one on scene of a hazardous material incident. Most important thing you can do with a hazmat incident is maintain a safe distance. Don't go near it. Unless you're a hazmat technician, you ain't got no business down there. Even if you are a hazmat technician, if you're on an ambulance, you still ain't got no business down there. Because being a hazmat technician on an ambulance is about like me being a paramedic in Target. I ain't got nothing to work with. Neither do you. Maintain a safe distance. Use the binoculars in your emergency vehicle. Every ambulance paper it has a set of binoculars in it and an emergency response guidebook. Identify what you're dealing with. Radio it in. Tell everybody else what you're dealing with. Look it up in your ERG. Figure out what that is that you're dealing with here. And we're gonna have a whole chapter on hazardous materials where we go over how to read the ERG and everything else. Recognize any potential problems. Like, okay, yeah, that glowing green liquid that is leaking out of that tanker truck that looks like something out of a cartoon. Yeah, that's running downhill into a creek bed, which later leads down the road to an orphanage. Okay, yeah, that's a problem. We probably need to work pretty quickly here. Take action for personal safety. Take action for the safety of others. Try not to let people run up in there in the middle of this hazmat incident. And then notify a trained hazmat response team. So you just radio dispatch, tell them, hey, we've got a hazmat incident. Here's the placard number. Here's what we're dealing with. We're staged over here. We're going to need a hazmat response. They will get all the resources you need for you. Most important thing we've got to mess with a hazmat incident is we will not treat a patient, does not matter the extent of their injuries, until after they've undergone decontamination. Why? Same reason we're not going to rush up in there and become part of the problem. Because if they still have all of that nasty on them from that methyl ethyl bad stuff that just tipped over on the interstate, and we put them in the ambulance without them being decontaminated. Well, now you're contaminated, now your ambulance is contaminated, and you're all going to get sick together. Let the hazmat team decon your patient before you ever lay hands on them. Unfortunately, in today's day and age, you may be called to respond to a terrorist incident. It may be small or large in scale. It may be as small as, well, Fordyce, Arkansas. Okay. That was, for all intents and purposes, a domestic terrorist incident. It was a mass shooting at the Mad Butcher in Fordyce, Arkansas. If it can happen there, it can happen anywhere. All right. It could be as large as 9/11. It could be as small as that. But either which way, it may include chemical agents, biological agents, radiation weapons, explosive devices, firearms, armed assailants. Stay away from it until the scene is secure. May be called to support a rescue operation, which may include disentangling victims from fires, auto collisions, explosions, electrocutions, and more. Never perform any acts that you're not properly trained to do. And I wish there was another line in there that said never perform any acts that you're not properly equipped to do. It's like I just said about your hazmat technicians. Being a hazmat technician on an ambulance is about like me being a paramedic in Target. Doesn't make a crap. Okay. I don't have the equipment, neither do you. If you don't have the equipment, don't perform the task. Now, if you have the equipment and you're trained, you may work on an ambulance service that does auto extrication. There's some here in Arkansas that carry extrication tools. You're trained, you got the equipment, that's your job, go for it. But if you do not have the equipment, don't try and do something, even though you may have been through a class on how to do it. All you're going to do is make the situation worse whenever somebody with the equipment gets there. Some harsh realities about well-being is there may come a day when you have to make a calculated decision between helping somebody and maintaining your personal safety. I hope you choose your personal safety. Because if you have to stop and think about it, about whether it's worth it, you going out there and potentially getting hurt, then you've already subconsciously processed that this is a really bad scene anyways. Otherwise, you'd already been out there helping. Okay. So don't try and play the hero. Heroes end up in obituaries. Bottom line. Don't become part of the problem. You need to understand another harsh reality. Sometimes, despite your best efforts, sometimes a patient will die. Sometimes you can do everything that is physically possible to do, and that patient will die. Remember that scene safety and well-being are determined by the decisions you make under pressure. That's why it's important to stop, breathe, and analyze before you make a decision, especially one concerning your safety. Unfortunately, in today's day and age, you may also have to deal with violence against you, your partner, your patient, what have you. Have a plan. Wear safe clothing. Prepare your equipment so it's not so cumbersome. Always have a portable radio with you on a call that whenever possible needs to go away. Have a portable radio. And decide on safety roles. Decide who's doing what in the event that this stuff goes south. If you're approaching a potentially violent scene, one, police should already be there. It should be a non-issue. But however, say you're working in an area that there's not a cop, sorry. Survey the scene on approach. Don't announce your arrival. Turn off your lights. Turn off your siren. Go in dark, essentially. Observe for signs of violence. Observe for signs that this may be a crime scene. Observe for alcohol or drug use. Look for weapons. Look for family members, bystanders, potential perpetrators, pets. Make note of everything. I do this even on calls that I don't necessarily consider to be violent. I don't just flat foot that door and knock on it. In law enforcement, we call that a fatal funnel. They can just start shooting through that door right there and they can nail you. I always, whenever I knock on a door, if any of y'all end up riding out with me during your clinical time, you're going to notice I stand to the side just like they do and I knock on it. I don't know why he's got like the Hog Hunter 5000 spotlight right there, but to each his own. In order to react to danger, remember the 3 R's. Respond, which means get yourself out of the situation. Radio in what happened, get some help coming to you, and then reevaluate. Don't re-enter a scene until it's been secured by police. If the scene was not originally intended to be a violent call or a dangerous call to you, and you get there and then it is, get out of there. Leave your equipment. We can buy more shit. Leave it there. Get out of there. Call the police. Let them get there. Let them secure it before you ever come back up there. Run. Get out of there. It's not your job to sit and fight. It's your job to get out of there and call for help. I understand a lot of country boys in here. I understand everybody knows how to fight. Everybody knows how to shoot and everything else. And this role ain't your job. It's a tough pill for me to swallow sometimes too. Just get out of there and call the police. Let them come out there. That's their job. Let them do it. Don't put yourself in a bad situation. Get rid of any cumbersome equipment. Drop it. Don't worry about trying to grab your bag up out of there if somebody's running at you with a knife. Leave it. We can get another one. I don't care if they steal it. I don't care if they destroy it. Leave it. We'll buy another one. Take cover and conceal yourself. By any questions over the well-being of an EMT? You need a break?
No, I'm good.
I'm good.
Moving right along.
I'm good.
All right, this next one's not as long, don't worry. All right, go over lifting and moving patients. We're going to do this on your Saturday class on the 21st. You're going to have to pick people up. It's the nature of the business. It's unfortunate. They're probably going to be bigger than you. They're going to weigh more than you sometimes. Sometimes you're just going to have to do it. You're going to have to pick them up. Protect yourself with as best you can. Use proper body mechanics. Use your body properly to help prevent injury and facilitate lifting and moving wherever possible. Consider what you're doing before you lift any patient. Consider the object. Consider whether it would require additional help to lift. Know your limitations. Know your partner's limitations. Make a plan and communicate it with your partner before you ever try to lift. Don't just go snatching folks up. Some people get hurt. Position your feet properly. Lift with your legs, not with your back. Never turn or twist while you're lifting somebody. That's how you hurt yourself permanently. Do not compensate when lifting with one hand. Just don't lift with one hand. Keep the weight as close as possible to your body, and then use a stair chair when carrying a patient on stairs whenever possible. That's a stair chair there. We're going to play with one on the 21st. If you have to reach over and pull something to you, keep your back in a locked in position. Don't twist while you're reaching. Don't reach more than 20 inches out in front of your body. Avoid any kind of prolonged reaching if there's going to be strenuous effort required. Push, don't pull whenever possible. Always keep your back locked. Remember, always keep your weight close to your body. If the weight is below your waist, don't bend over and do it. Kneel down and then push or pull from the kneeling position. Don't push or pull overhead. That's how you get knocked out in the face. Keep your elbows bent and your arms close to your sides. All right, something you're gonna have to take note of. Different types of moves. There'll be questions about this. So there's your emergency moves, your urgent moves, and your non-urgent moves. So your emergency move is to get a patient out of a hazardous situation. So you get there and your patient is in a vehicle that has now caught fire. Okay, and you can snatch them out of there real fast. I'm not worried about their injuries. I'm not worried about protecting their cervical spine. I'm not worried about any of that. All I'm worried about is getting them out of that hazardous situation. Some ways you can do emergency move: closed drag, incline drag, whatever that is, firefighter's drag, I guess. I don't know. I'm not doing that one. A blanket drag, so you can put them on a blanket or a mega mover, drag them out of there. One rescue assist, if they're somewhat ambulatory, you can assist them down there. Man, he looks happy to be here, doesn't he? Two rescue assist. Then there's an urgent move, which means a required treatment can be performed only if the patient is moved or the factors of the scene are causing the patient to decline. It usually involves moving the patient to a backboard, getting them out of there. Then a non-urgent move is the most common type of move. There's no immediate life threat. Patient can be treated, assessed, moved in the normal way. Take all precautions not to aggravate existing conditions. That's why we're going to be real gentle, real careful, moving real nice and neat and everything else. And because we're not in a hurry, it's nothing that has to be dealt with right now that's impeding where they're at. So a couple of different patient carrying devices you're going to deal with. You have your wheeled stretchers. So this may be a power cot, a manual cot, a bariatric cot. Bariatric cots are weighted to carry patients ranging from 800 pounds or more. A lot of times they're operated off of winches. We don't have one because we have power load cots. They will lift up that. That's what a bariatric cot looks like. He's grabbing the winch right there. Just going to hook it up, snatch him up into the ambulance. There's stair chairs, which is essentially just a wheelchair with sometimes there's treads on the back of it, but usually there's just handles on each side of it so you can carry. Uh, there's short and long spine boards. Short spine boards are pretty much a thing of the past. We don't even practice with them anymore. You're not going to have to worry about those in this class. Long spine boards are still used, uh, especially when you remove a patient from a vehicle with a neck or spine injury. Where there's a suspected neck or spine injury, that's the only way you can get them out. So that's a stair chair. There's long spine boards there. Some other types of stretchers you may end up dealing with is a portable stretcher, or a folding stretcher. There's a scoop stretcher, which you will play with in this class. Basket stretchers, uh, flexible stretchers we're not really going to deal with, and then a vacuum mattress that's also kind of a thing of the past. That's a scoop stretcher. It comes apart at each end. You go up on either side of the patient, you lock it back into place, and then you lock the bottom into place, and it essentially just scoops them up, hence the name. That's a basket stretcher or a Stokes basket. These are commonly used in rescue situations, search and rescue situations, things like that. That's a flexible stretcher. That's a vacuum mattress. Like I said, they're really not used much anymore. They used to be pretty common, like in industrial settings or theme parks, stuff like that. You just really don't see them much anymore. Before you move a patient, if a patient has a suspected spinal injury, and we'll go over that when we get into trauma, you will mobilize the head, neck, and spine before you move, either through manual stabilization or a rigid collar. You will restrict the movement of their neck and spine so they don't further aggravate their injury. If they do not have a suspected spine injury, there's a couple different moves you can use. You can use the extremity lift. Uh, this can be used to carry a patient to the stretcher or the stair chair. We use to lift the patient from the ground or from the sitting position. It looks like so. One person gets up under their arms, another person gets up under their legs. You can go all day long like that. There's a direct ground lift, so you can lift from the ground to the stretcher. You get on either side of them, look for laying spine on the ground, and you can go from the ground up onto the stretcher. Up onto the stretcher. Most commonly used one is going to be the draw sheet method. So you get a sheet up under them, slide them from one to the other. Roll them, get the sheet under them, pick them. You can use it to pick them up, move them, slide them. Position you need to know is the recovery position. So, or the left lateral recumbent. The recovery position is when you lay the patient on their left side to avoid uh, any kind of vomitus or anything going back and down the airway, allow everything to run out of the mouth. And we'll talk more about that as we get into airway as well. Sometimes you may have to position a patient a certain way. So if you position a patient for shock, you place the patient into the supine position. When you arrive at a hospital, you move the patient from the ambulance stretcher to the hospital stretcher. It's most commonly done with the modified draw sheet method. So just like so, just like we showed earlier, it's not a whole lot that's been modified about that, but that's modified apparently. Any questions over lifting and moving patients? Going once, going twice. Bueller.
No, I'm good.
I'm all good.
Yep. Try and get this next one pulled up for y'all.
While you're doing that, Jake, I'm gonna take a bathroom break real quick.
Yeah, y'all take you about 5 minutes. We'll get started in about 5 minutes. Everybody back?
I'm back.
Okay, we'll be back. All right, if you're not here, raise your hand.
Not here.
Sweet. All right, let's keep going. All right. So some medical, legal, and ethical issues you will deal with as an EMT. Tyler, do you have a question?
No.
I said you raised your hand. All right. So your scope of practice. Your scope of practice are your regulations and ethical considerations that define the scope, and or the extent and most commonly the limits of what an EMT's job is. Basically, it is your scope of practice are the skills that you are allowed to do, what you can do versus what you can't do. Everything that you are allowed to do as an EMT, either through state protocols or your local protocols or what your medical director allows you to do, is your scope of practice. Your standard of care, however, is the care that will be expected from an EMT with similar training when caring for a patient in a similar situation. So your scope of practice is what you can do, and your standard of care is how you should do it. Standard of care is nationwide. Standard of care is what you can expect in Seattle, Washington, or Orlando, Florida. It is what you can expect to receive from an EMT with similar training in a similar situation. Matters you're going to run into a lot is patient consent. Patient consent is permission from the patient to assess, treat, and transport them. So you have express consent, which must be informed. Means that, hey, can we treat you? Can we take care of you? Can I take a look at you real quick? They have to say yeah or not or something like that. They know what you're trying to do and they give you permission to do it. Implied consent is assumed consent. So implied consent applies to children and mentally incompetent adults. Uh, Minors are not legally allowed to provide consent or refusal from treatment. Consent must be provided by a parent or a legal guardian under some possible exceptions. So one possible exception is in loco parentis, which is a Latin term that means in lieu of parents. That's usually you run into like in schools, daycare centers, stuff like that. If the parent has allowed the school or the daycare or the child care center or wherever they are, church, what have you, to make medical decisions on behalf of the child if the parents aren't present. That's in loco parentis. Another situation that's not as common to run into, but you may deal with it, is an emancipated minor. So an emancipated minor is somebody who is under the legal age of 18, but has essentially been emancipated, which means that for all legal purposes, they are an adult for a couple of reasons. Either they've gotten married, they've had a child, they joined the military, something like that that allows them to now make their own decisions. There are some exceptions for you obtaining consent. If you arrive and there's a child with a life-threatening illness or injury and the parent isn't there, that is where implied consent comes in. We would assume that that parent will want us doing everything to take care of that child. So we're not going to wait on mom and dad to show up to the accident scene, 25 minutes from now with their kids bleeding to death. We're going to scoop the kid up and we're going to go to the hospital because that's implied consent for us to do that. There are some times where you will take a patient without consent or against their will, involuntarily. If a patient is considered a threat to themselves or others, we have the right to transport them to the emergency department against their will for evaluation by a mental health provider. If we have a court order to remand the patient to a hospital, we can take the patient into our custody and transport them to the emergency department. Anytime you're going to do any kind of involuntary transportation, you need to have law enforcement with you. You need to have the police there, standing by and ready, just in case it goes very much sideways. If you have to restrain the patient, make sure that they stay okay the entire time. I understand that you probably had to fight them the whole way into that ambulance. However, they're still your patient. You are still responsible for them. You still have to make sure they're okay, whether they're restrained or not. Another thing you have to deal with often is when a patient refuses care. This happens a lot. A patient may refuse care transport if they are legally able to, they are awake and oriented, so they can be awake and confused out of their mind. They can't refuse care because they're not competent. They must be fully informed of what they are refusing. It means we have to tell them what they're refusing, and then they have to sign a release form. What this is supposed to do is not hold us liable. Despite all the precautions, you may still be held liable if something goes bad and they refuse care. That's why it's important to document, document, document everything that happens on these calls thoroughly, especially on a refusal. My refusal charts are almost twice as long as my non-refusal charts. So I put down every little detail of what happened while we were there, what I saw, what I told them, what they said, and why they didn't want to go. Okay. Make sure you cover all of your bases on a refusal. Try and persuade them to go to the hospital. Spend time talking to them. Listen and try and determine why the patient is refusing care. Are they refusing care because somebody else called for them and they didn't want you there in the first place and they don't think anything's wrong with them? All right, that's probably fair. Sign here. Thank you. Or are they refusing care because they're worried about financial ramifications? Are they refusing care because of they don't like the color of your partner's shoes? I don't know. Figure out why they don't want to go to the hospital and then try and get them to go to the hospital. Inform them of the consequences of not going to the hospital. This is an absolutely essential part of every refusal of care situation. Tell them what could happen if they don't go. Consult medical direction when possible. Try and get your doctor on the phone. Maybe your doctor can talk to them. If you subject a patient to unwanted care and transport, you can be charged with assault or battery, depending on your state statutes. You need to make sure that if you are providing care or transport against their will, they have met one of these above criteria. Where is that? That we talked about earlier. Okay. If you can, have a patient or have a relative or friend of the patient remain with the patient just to make sure they're going to be okay, check on them, stuff like that. And then document all of your attempts thoroughly. Like I said, make sure you document, especially on a refusal. Some other legal documents you'll come in contact with the longer you do this are do not resuscitate orders. A DNR order is maybe part of an advanced directives. It may be part of a physician order of life-sustaining treatment. Ultimately, what it boils down to is the patient is obviously unresponsive, pulseless, and apneic, and they don't want us to do anything. Uh, if they become unresponsive, pulseless, and apneic, they don't want us to do anything. It is a document that states the patient's wishes if they can't speak for themselves. Any questions? All right. Some other terms you should be familiar with. Negligence. Negligence is when something that should have been done either was not done or was not done correctly. Uh, in order to prove negligence, they have to prove that you had a duty to act and then you breached that duty. You failed to meet your standard of care that we talked about earlier, or you just failed to act. Then you could be guilty of negligence. They must also prove proximate causation, which means that the patient suffered harm because of your action or inaction. And you can be held liable both in criminal and civil court because of this. As far as a duty to act goes, a duty to act is defined as an obligation to provide care to a patient. It's not always clear. What if you're off duty? What if you're on duty, but you're outside of your jurisdiction? It's always important to know your local laws and protocols and always, above all else, follow your own conscience. Uh, in the state of Arkansas, you have a duty to act once you've identified yourself as an EMT. So if you say, not just because you have a sticker on your truck or whatever, but you say, hey, I'm an EMT, you now have a duty to act and provide care to this patient until somebody else takes over from you. It doesn't matter if you're off duty, if you're on duty and coming back from a transfer and you're driving through Timbuktu, you roll up on something, well, you've kind of identified yourself already by the fact that you're in a big old ambulance and you're in uniform. You kind of have a duty to act until somebody else gets there. A breach of duty to act is classified as abandonment. So abandonment is once care is initiated, it can't be discontinued until it is transferred to the medical personnel equal or greater training. So once you start working on this patient, either somebody at the EMT level or higher has to take over care from you. You can't just stop, go away. and leave. That's abandonment. You can be held criminally and civilly liable for it. So some things that protect you, there's Good Samaritan laws. Good Samaritan laws grant you immunity from civil action and criminal action if you act in good faith and within your level of training. It may not cover EMTs in some situations. It may not cover you if you're on duty. Usually, this is what's going to cover you if you're off duty and you come upon something. It does not protect you from gross negligence or violations of the law. Just because you arrive on scene of a car wreck and you're an EMT, well, if you go up to that car wreck and start trying to act outside your scope of practice and pull a Nancy Drew and crack this guy with a pocket knife and a ballpoint pen and he dies, that's still going to be on you. You're still getting charged. Just I didn't get Samaritan law or not because that's gross negligence. Confidentiality. You're required to maintain confidentiality in everything you do. Information on the patient's history, condition, treatment, it's all considered confidential. All of this information, including the patient's identity, is protected under the Health Insurance Portability and Accountability Act, or HIPAA. Everybody's heard of HIPAA at some point in time or another. Information may be shared with other healthcare personnel as part of the patient's continuing care. That does not mean you can talk to your buddy about what happened to Mr. John Smith around the corner when you get back to the station from this call. That is a breach of HIPAA. But you can tell the nurse or paramedic or doctor or whoever is taking the patient from you at the hospital who this patient is and what's going on with him and what you've done. That's not a breach of HIPAA. Any information that is protected by HIPAA that is not being provided from one patient care provider to the other in the course of the patient's care must be obtained through a subpoena or a court order. Some patients you deal with may have medical identification devices. These are especially useful if the patient is unconscious or can't speak for themselves. It may tell you a little bit of why you're there. It may tell you a little bit of what may be going on with this patient, why they're in this current state. Very common ones are for diabetics or people with severe allergies may wear a medical alert bracelet. Patients who have seizures may wear a medical alert bracelet. So it's always something to look for. It could be a bracelet, it could be a necklace, it could be an anklet. There's all sorts of different types of ones. So when you're doing your patient assessment, just check for them real quick. It doesn't take any time at all. Don't worry about that. Safe haven laws are a thing that's coming to Arkansas. Well, they're already here, but they're getting more and more popular. So the safe haven laws allow a person to drop off an infant or child at any fire, police, or EMS station. Different states have different guidelines for how old the child may be to drop them off. But what it does, what it's designed for, is to protect a child that may otherwise be abandoned or harmed if the parents are unwilling or unable to care for them. It's to prevent dumpster babies, basically. So the safe haven baby boxes that you see in fire stations, they just put one in East End. We're getting one installed in Sheridan. Benton's got one. They're popping up all over the place. That's a box that's provided under this law to allow a safe place for a parent to surrender their child if they can no longer or are unwilling to care for it. So I say all that to say this. If you get called to a baby box activation, that's your baby until you get to the hospital. You own it. Whoever takes that child out of the box, that's your kid till you get there. You're essentially a mother or a father for the next 25 minutes till you get to Arkansas Children's Hospital. You may be called to enter crime scenes through the course of your duties. Once the police have cleared the scene and waved you in, your number one priority is patient care. However, you need to be able to recognize what could be considered evidence and try and preserve that when possible. Ultimately, life safety takes precedent over everything. If you destroy evidence in the course of providing patient care and you had to because, oh well, that's what it took to keep this guy alive, nobody's going to care about that. But don't just go traipsing through and digging through stuff and everything else and destroying this crime scene just because you're there. Uh, some examples of what could be considered evidence are the condition of the scene. Was stuff turned over, were light switches turned off, were light switches turned on and don't turn them back off. Was the TV set on something? Were tables knocked over, flipped over, was a window busted out? Don't go try and change anything about how you found this house. The patient themselves can be considered evidence. Uh, Fingerprints, footprints obviously can be considered evidence. And there's microscopic evidence you can't even really see. Remember what you touch. Remember uh, what way you came into the scene, uh, and then go out that same way. Try and minimize your impact on the scene, and then work with law enforcement. I'm sure one of them be happy to guide you and tell you, kind of where to walk if possible, and what to touch, what not to touch. As an EMS provider, you are a mandated reporter in the state of Arkansas, which means you are required to report any signs of child, elderly, or domestic abuse, any signs of human trafficking, any violent attack, any sexual assault or suspected sexual assault, or situations where other restraint may be necessary. The abuse is usually reported through DHS. There's a form you would fill out. Your medic, whenever you start doing your ride time, kind of show you how to go through that. Uh, Human trafficking, violence, and sexual assault are where you will call for law enforcement to the scene. You do have some ethical responsibilities as an EMT. Uh, Difference between morality and ethics is morality is a personal opinion about what you consider to be right and what you consider to be wrong. Ethics, on the other hand, is a standard of behavior for a profession. The ethical expectations for an EMT is you should be honest, refrain from actions that will cause harm, and work to help the patient. We need to be able to trust you. We need to trust that you will do no harm, and we need to trust that you will be an advocate. As an EMT, your ethical expectations are you should respect the right of an adult patient to make their own decisions. All right. You're not there to make their decisions for them unless they meet one of the criteria we talked about earlier. Treat all patients fairly and justly, regardless of your opinion about them. Assist others to learn about your profession. Teach them about what we do. We're still a very underrepresented form of emergency services. All the shows you see, for the most part, are about fire or police, because those are the big ones. We run more calls than all of them, both of them put together in most places. And yet we're still underrepresented. People don't know what we do. Teach them about it. Report any allegations of misconduct, and then make sure your research is approved before you act on it. Any questions about legal or ethical issues? Comments, concerns, donations? Very good. All right. Last chapter of the night. It's been fire hose learning today. I apologize. These are a lot of the dry chapters. Last chapter, medical terminology. So you will have to deal with medical terms in this profession, obviously, as you're an emergency medical technician. Uh, there's a couple different types of medical terms. So could be a compound term, which is made up of two or more words. Uh, these words will have a root and then a prefix or a suffix. So, for example, therm means heat. So a thermometer is something that measures heat. There should be a whole chapter on this that you need to kind of know some of your prefixes and suffixes because it will help you on your questions, and I'll show you all how on our next skills day. So, for example, a cardiologist, cardio means the heart. Ology means the study of, and ist is one who specializes in. So cardiologist is therefore one who specializes in the study of the heart. Other things you'll deal with is abbreviations and acronyms. So abbreviations are made up of initials that can pronounce as a word. So for example, CPAP, pronounced CPAP, stands for continuous positive airway pressure. Compound word cholecystitis. Chole means bile. Cyst means closed sac. Itis means inflammation. Symbold means bile sac inflammation. So cholecystitis is an inflammation of the gallbladder, which is your bile sac. It's where it stores bile. Don't use medical terms when speaking to patients or family members. Use plain English. Complex terms and messages can even cause confusion over trained healthcare professionals. It's always better to, if in doubt, it's always better to use simple terms. I use plain English most of the time. I try to avoid my use of medical terms in my reports, both written and oral communicated. I like plain talk. However, you do need to know what these medical terms are because they may be in documentation that you have to review while you're taking care of your patient. So you have anatomy and physiology. So anatomy is the study of the body structure, and physiology is the study of the body function. So anatomy is how it's set up, and physiology is why it works the way it works. So some anatomic terms, you have your directional terms. Directional terms are based off of anatomic position, which is facing forward, hands at the sides, palms facing forward. When you divide the body into planes, you have your midline right down the center of your body. Anything that is medial is closer to the midline. Anything that is lateral is further away from the midline. So medial is close to the midline, right down the center of your sternum. Lateral is further away from your midline. Bilateral means on both sides. So for example, if you had two broke arms, a broke left arm and a broke right arm, say you had both of them were broken in the forearm, you could say the patient had bilateral deformity of the radial ulna area. Unilateral means only on one side. So when dealing with your mid-axillary line, so take a line right down the center of your armpit, all the way down all the way down your side. That's your mid-axillary line. Okay. If it's anterior, it is to the front of your body from that mid-axillary line. If it is posterior, it is behind that mid-axillary line around your back. If it is superior, it is above that. If it's inferior, it's below that. So there is your head, north side, your lower extremity. Can y'all see my mouse?
Yeah, I can see it.
Yeah.
Okay.
Yes.
I don't know if
Yeah,
y'all can
we
see
can
that.
do that.
So you have your midline right down the center, then your mid-axillary line right down here. So your midline defines medial, which is closer, versus lateral, which is away. And then your mid-axillary line describes anterior, which is front, versus posterior, which is the back. Does that make sense? Oh, there it is. I don't know. There's the next slide. There it is, right there. So your midclavicular line divides your chest into a couple of planes. You have your frontal plane, which goes side to side. You have coronal plane, which goes front to back. Your transverse plane, which goes up to down. That's kind of how you're going to dissect your body into a couple different areas. This is one of the chapters I want to make sure y'all read very closely, and pay close attention to how your terms are set up and compounded, and how the words are compounded. That way you understand as we go a little bit further into these chapters because they're going to use a lot of these terms.
Note cards is your best friend during this.
Do your note cards. All right. So you have your abdomen is divided into 4 quadrants. You have your right upper, right lower, left lower. Excuse me. So there's that line there, goes right down the center of your belly button. You have your right upper, your left upper, right lower, left lower. It is always patient's right and patient's left. It's never your right and your left. It's always patient's right and patient's left. So as you get into your anatomy and physiology chapters, you're going to learn what's in each quadrant. So for example, your right upper quadrant mainly composes of your liver and your gallbladder. Right lower is where your appendix, kidneys, colon, stuff like that is. Left upper, you're gonna have your stomach, your spleen, another small part of your liver. And then left lower, you're gonna have more intestines, your colon, uh, ureters, kidneys, and issues like that. So as you're starting to assess your patient, as you can kind of determine, like say they're having abdominal pain, you can determine what may be an issue here, depending on where the pain is. So positional terms, very important for you to remember. Patient is supine, they are laying on their back. If they are prone, they are laying face down. If they're in the recovery position, they're laying on their side. That's preferred for any unconscious non-trauma patient. So supine, prone, recovery. Other positional terms is the Fowler position, is when the patient is seated straight up. Semi-Fowler was when the patient is leaning back in a semi-sitting position. So like so. Most common position on a stretcher is a semi-Fowler's position. Any questions over medical terminology? The chapter I want to make sure y'all read very thoroughly and understand your terms because we're going to talk about it on this next Saturday class. Any questions over anything we covered tonight at all? Stupid questions, the one you don't ask.
No, I'm good.
Well, thank y'all. That's all we got for tonight. Make sure you get your assignments done. They will be due on Sunday. Make sure you do your reading, take some good notes.
Go ahead.
We will see y'all on next week.
Thank
you,
you.
sir.
All right. Thank you, Jack.